Namaskar. Good morning to everyone. And thank you for the opportunity to speak here. I am Aruna Abhyankar. I'm going to speak on the topic as you can see. And this presentation is not going to be just my presentation. I'm going to present some slides and then invite the faculty who are here, my co-faculty, to come and join the discussion. So I hope the mics will work for them as they individually want to speak in between. So the focus is on wider implications. We are not going to give a didactic talk. And I have tried to highlight some of the important points of consent. So the society and our profession have had an interesting relationship. We are revered, respected, hated, criticized, everything. And the most important aspect of our work is do no harm. And often we think only about clinical harms, but we have to also consider financial and mental harms. And sometimes these are more important when legal cases crop up. We would like to believe that the system works with trust, empathy, and concept of duty. However, what goes in the courts or when the complaints occur are about service, business, and regulation. And we have to be mindful of patients' rights, organizations' regulations, and consider whether all of us are always the good people. So the legal cases are quite interesting to reflect on, and I'm just going to quickly go through them. So this is a case about, well, more than 100 years ago, where it was firmly stated that a surgeon can't take liberties with a patient, in effect. But what is interesting to note, that the hospital was not held liable because it was a charitable institution. And this went on for a few years until it changed. So this was a case of cautery burns, and there was a preoperative application of antiseptic. Now, I didn't know until I researched on this topic a couple of years earlier that the case was that old. And it was agreed that the application was a surgical step. It was also judged that it is not the job of the anesthetist or the nurse to stop you from doing silly things as surgeons. So just be mindful of that. The hospital was held liable for this action, and the same thing happened in another case. This case is important because the patient was referred to another surgeon, and the doctor who was referring the patient was not held liable because he acted appropriate for the need of the patient. And then we know all about Bolam and Bolitho cases. And the important thing to remember is previously, if 10 experts go and say, this is right, it was believed to be right. But Bolitho case is quite breakthrough case because it stated that the expert opinion has to be logical, not just an expert opinion. So it was a move away from the mandatory acceptance. And so for reference, these are the points of informed consent that a judgment has said must be included in our discussion. And many of you must have heard about Montgomery judgment, where it reasserted that reasonable and relevant consequences must be explained. For example, this lady was shot and she had more high risk of certain complications, and the doctor has to be mindful that the complications are going to be more than uncommon for this lady. So this brings me to the next aspect of my talk, where I am going to start inviting my panelists to start joining into the conversation. So one of the first topic which I have put up is, because we all do robotic surgery, laparoscopic surgery, and leave the trail of various clips and trips inside, is product usage and the liability. So this is a very famous case of breast implants where it is not the surgeon who counseled, but it is a manufacturer who did not convey the risks to the surgeon appropriately enough, and hence to the patient was judged against them, and they were responsible for the consequences. The company actually went bankrupt and people didn't get enough money back, but that was an important thing. And there are some more aspects of it. This particularly, Professor Mohta can talk about, if it is possible, yeah, about products.
Hello. Yeah, good morning. Actually, consent is required for products, especially where one thing is what technique we are using, technology we are using. We have to explain to the patient what technology, which is better, laparoscopic versus robotic, or robotic versus open. All the opportunities have to be given for patient to understand the same, and then he can choose which is better. It cannot be a whims and fancies of the surgeon to choose a particular one. The option has to be given to the patient, what he chooses. It may have a lot of consequences of patient himself also. Our aim is to explain to him the advantage and disadvantage of the same. Another point which I wanted to talk about was it's important to inform the patient regarding the reuse of the products. A lot of things are first time single, most of products are advocated for single use. But many times in our logistics and all that, to meet our logistics, we have to reuse the items which may otherwise be single use. That happens in India actually, and many other products. So it is our responsibility to explain to the patient that what are the consequences of reuse, what are the advantage of reuse. That is one thing. Advantage is the lower cost because we are reusing and sharing the cost with some other patient. So that's one thing I understand. Thank you.
Yeah, thank you. So the cost if benefit ratio we have to consider, but be honest with the patient. And also another important thing to note that we are using things which are supposed to be approved for a certain use into another way. So for example, nasogastric tube is used as a urethral catheter. We accept it, but sometimes we are stopped, and that's because of the hospital policy. So we have to be clear about what regulations we follow.
Aruna, can I just also come in and say,
Yeah.
most of us will use a particular product for something else than what it is supposed to be used for because it is available and we don't have something at exactly that time. And we say, oh, this catheter, okay, we can use it for something else. If it is not in the product information that this can be used, you could be held liable for that. So always check the product information and what the company says what the product can be used for. We try to do a jugaad sometimes because we don't have certain things, but that can be misfiring.
Now, there must be some trainees here, or many of you are trained, hundreds of trainees. So, what is the responsibility of a trainee, and what is the indemnity or cover they get? Now, it is important to remember that every doctor should have some basic idea, and according to their level of training or medical training, they should be able to understand what consent is. So, this is another famous case in Lewisham that is in London, and this where the doctor took certain actions which a consultant wouldn't have taken, but he was not held liable because he was quite junior, which was acceptable. However, part of that was he acted without taking appropriate consent. And not taking appropriate consent means he did not act properly or he breached the regulations. So, this is important because of the training responsibility all of us have. Anyone wants to join on this or? Yeah.
See, when we talk about putting a cannula, normally the consent will be a oral consent. We don't take a written consent for that. But when we talk about the seniors being responsible, we are talking about vicarious responsibility, which is there for all surgeries or whatever my team does. I am the head of the team. I am responsible for it. That is the way I think we should understand that whole thing.
Yeah, one case I come across recently, as simple as that, in meconium ileus, sometimes we give rectal washes to confirm whether it's meconium is there or not there and all that. And it was done in one of the cases which came recently, and the father questioned that they didn't take consent for a rectal wash, as which we consider the routine in our clinical practice. But he complained to the competent authority that a consent was not taken for doing a rectal washout and could have led to perforation and all that. He was a knowledgeable person. So we have to be very careful. while doing any invasive procedure
Yeah.
of any sort, we have to take a consent.
Yes, absolutely. Thank you. So the responsibility does lie with the trainee as well, because you are a qualified doctor when you come into the profession to train up as surgeon or a pediatrician or whatever. So you can't just say that the boss is responsible for everything, but when you are consenting, you have to make sure you cover everything and document properly. Now, we come to an interesting thing. This has happened that article had to be withdrawn because the patient became aware. So all this information is on the Google. So consent before you send in publications are extremely important. I personally know of 2 trainees whom I had to stop and ask for a withdrawal of their submission because they had not taken permission from all the authors. And this can be a serious breach and can backfire very badly on the department. Yeah.
I did have a similar experience. One of my trainees published a case report. The child had Curarino syndrome and several other problems. The mother actually identified from the published case report that this case report is about my child and actually complained to the publisher that her consent was not taken. The doctor was then held responsible, but I was the supervising author. So it took a lot of paperwork. Eventually, the article was withdrawn. But because there was no clear communication between myself and my junior, who had not even informed me that he is publishing the material, uh, that that meant that only the junior doctor was responsible. I think it is very important. We all want to publish, but make sure that when your juniors are writing reports and everything, all the T's and I's are properly crossed and dotted.
So we have a blanket consent for that nowadays, where before surgery we tell that photographs will be taken, it may be published, everything is written in that. But I don't know whether in the court of law it will hold good if you have a blanket consent like that.
So I just want to make a comment on that, that this is a problem. Unless there is a very clear structure for everybody to follow, there can be these confusions. And sometimes the law only comes into development because some issues have occurred. So the reverse way it happens. Another thing I must mention, which is not in the slide, is accessing patient information without ethical permission of doing a particular study itself is a consent breach, because that is the patient's identifiable information that shouldn't be accessed. I'm going to mention an interesting case, an unfortunate case for a very rare pathology. An Indian origin but British doctor died after significant complication after an invasive procedure. This happened whilst the patient was fully involved in the conversation with the treating specialist, so one of the rare other specialists, and this complication happened. Now, the inquest has led to some interesting findings that the doctor-patient relationship was not doctor-patient relationship, more like colleagues talking to each other. So it should be very important that even if the professor is admitted or somebody senior is admitted, you stand back and say, here now you are the patient, I am the surgeon, I'm going to discuss with my MDT and keep that barrier. Otherwise, emotions, taking for granted, confusions, all can set in. And the patient may not actually get time as a patient. He's getting time as a specialist, not time as a patient. And it can mask the Swiss cheese effect. Things were missed. A clotting profile was missed because everybody assumed the other person, the other specialist has checked it for each other. So just be careful about these effects happening in your real life. Parental responsibility. There are significant variations. I will invite Nitin to talk about the Gillick competence, but just want to mention that the age of child, what is child, changes. UN says 18 years. In UK, most of the organizations stop at 16 years. What happens 16 to 18 is anybody's guess, so this can be confusing.
Gillick competency came out of a child or a girl who wanted to get contraceptive pills and she could not get it because she did not have parents' consent. She went to the court and said, I'm competent enough, I'm pregnant, and it should be my choice. And the court upheld that the under 16-year-old had the mental capacity to understand the consequences, and that's where the Gillick competence comes in. So under Gillick competence, if a surgeon feels that the underage child has got the mental capacity to understand everything about the operation and its consequences, and the parents are not either available or they are not ready to consent, then the child considered Gillick competent can consent for the procedure. A 16 to 18-year-old will normally be considered Gillick competence. The problem comes when you've got a 14-year-old or even a 13-year-old, and it is the surgeon's responsibility to document that, in their opinion, they are Gillick competent.
See, this age group itself, I think, is very dubious. Even in India, if you see, few of the hospitals consider till 12 years as children. Few of the hospitals will take 18, few of the hospitals will take 16. So there is no fixed criteria as to who is the child and till what age they can consent or parents have to consent. Supposing a 16-year-old girl comes with pain abdomen, ultrasound finds she is pregnant. So can we go for a MTP or we have to ask her or the parents? So these are very unanswered questions which we should be aware of.
Thank you. Also, I have just mentioned the third point, sperm donation outside the normal processes. This is a big problem coming up, but I won't spend time on this. I just want to highlight one thing, I'm conscious of time, that informed consent also refers to non-operative practices, so not doing operation or taking any alternate options, but is also covered in informed consent. I'm identifying some recent social media access to mobile practices, and which are there in yellow-orange color, is patient identifiable information. We are still getting on WhatsApp photographs of X-rays, CT scans emblazoned with the patient's name. That is a clear breach of patient's confidentiality. Every country may have different regulations, but what you have to be aware that the apps that you are using might have control elsewhere in another society and another country, and the liabilities can be quite complex. So just be mindful of that. Tasmit, you want to say anything?
No, that's fine.
And finally, mentioning never events, the word never event is used, but it is to be sort of, there are lots of regulations around it, or other caveats around it. And some of the events that you might think should be called as never events are not there, but legally, if it is classified as never event, in UK there are few events that are classified, it is a big liability issue. So summary, surgery of rare and complex cases can be a challenge. Lack of access to all previous medical history can be a challenge. Lack of evidence can be a challenge, which all applies to a lot of you here in the practice. So, and there are lots of variations. But the real problem now that is coming up is a distortion of what is a risk factor or what are the consequences of a particular surgery or a procedure or process is becoming quite important. You will get WhatsApp queries on things like I got recently a petticoat cancer and I'm wearing a sari today, so I was very mindful. But practical challenges are these that a doctor should be aware of. Administrative accountabilities. What are the rules? What is the contract that you have signed? You might be working in different hospitals and they all will have different rules. Language limitations, when you're talking to patient with different language, you may not be able to express completely in your language or in English or Hindi. We may not be training people properly, and we have to understand, and whether we are very paternalistic and tolerating other people preaching and paternalizing other people, and whether we are sharing information on our mobile without realizing that we are. And I'm just wanting to remind you that just because we are doctors doesn't mean that we are not psychopathic. There are quite a lot of incidences ongoing. Regulations come into picture, but they are not followed and can be obviated. You might be asked to do video recording, might have to give real-time access to patients, and otherwise you have to remember that it is informed consent doesn't protect you from blame of negligence. Everything else matters. Thank you.
No, just a word on video consent. Uh, I mean, almost all the hospitals today are creating video kiosks, where it's not really a kiosk, it's a room. And before we take a video consent, we are supposed to take it in writing from them that this is going to be video recorded. So that's as important. And one way of doing it is, but the minute you say that it's going to be video recorded, the patient is already suspicious about why.
Right.
So it has to be done very subtly, but I think it is quite helpful. It may not be admissible as evidence of consent in court, okay? Because almost everything cannot be covered in your video consent, although we try to do it. Is a written consent which ultimately still overrules a video consent, but the consent of taking a video, that's one action. Second is the video consent itself, the recording, becomes a big dissuading factor for the parents or the relatives to, take you to court. That
Sure.
they know that we were already informed about this particular thing.
Yeah. And one word which I didn't mention is consent is a process. So not just the last video consent, whatever else you have done before, and you should take care to document everything.
I think we have discussed most of the general things, but there are special issues like a child surgery. Who gives consent, mother or father? If there's a difference of opinion between the two, who will do it? Then there are other instances like Jehovah's Witness, situations like that. And then gender reassignment. There have been issues regarding consent because patients have sued their parents and other people on getting adulthood that I was not a party to the consent for assignment of a particular gender. So all this has to be in the tricky situations, and the discussions can go on. But I think for the now, we can conclude at that problem.
Other thing I think we have to be worried today is about WhatsApp consultations. Very frequent patient will send you an image or a thing or a prescription saying, I am having this, can I do this, or what do you suggest? So I think we should be very careful about suggesting anything on WhatsApp, because that is not consented, I feel. We are just giving a plain problem answer to something which can be later on taken to a court and we can be landing upon problems.
And also, we tend to give advice on the phone a lot of times, and we never document it, but you can be held liable. I think in the court, anything that is written is accepted. Anything that is verbal, it will take a lot of convincing of the court. So you have to keep records, and even if you do a telephone consultation, you have to maintain a written record.
I think Shalini wants.
Thank you, Dr. Aruna, for a very nice presentation. Can you hear me? So what I wanted to ask is about the age of the patient and about assent, because we are all taking consent from the parents, but we have a lot of adolescents undergoing sometimes major surgeries, whether it's congenital anomalies or cancer, and ideally we're supposed to take the assent more than 7 years of age. So how do you do it? I know we don't really get a signature from the children in India, but we do explain to them. So how do you go about it?
So the important thing is that the conversations happen in front of the child in the words that he or she understands. That's first thing. Secondly, special precautions can be taken. I had an autistic child who was going to have augmentation. So we had to we did a flashcards for him, and every day small information was fed to him, and his teacher and parent acted together, and they fed back to me that he has this particular phobia, and he allowed only a certain catheterization, only certain act by me and nobody else, and we had to comply with his request because he was autistic. So we have to make sure that he understands in his language and is able to comply with that.
I think we can discuss the broad things in a clear, simple language with the child, 8 to 18, what are the differences are. Nitty-gritties can be discussed with the parents or the caregivers, responsible people. And in research, it's mandatory actually. In research, doing assent is mandatory, although we don't follow it so much in our clinical practice.
Yogesh, just before Yogesh speaks, the problem of assent has come up recently, but I think 8 years and beyond, it's very, very important to start taking the assent. I know we are not in a habit of doing that, but we should start doing that. Second point is, Indian parents especially have a habit of, tum log bahar jao. They'll send the wife out, they'll send the child out. I always insist, no, they have to hear of whatever is going to happen to them. So otherwise, we've had cases of fear psychosis, fear response, post-operatively or even intraoperatively uncontrollable children. So it's very, very important that the child knows, even if he's passively hearing, he is not actually passive, he's actively hearing on what the conversation is happening, even though we are addressing the parents. At the end of a consultation, I always address the child also, whatever age. I say, okay, so don't worry, आपको ठीक किया जाएगा, हाँ, आप एकदम अच्छे हो जाओगे. You just one thing like that, you have their confidence, you have their assent. Even if it's not in writing, you still have their assent, and that helps a lot.
Having done courses on ethics and having been on the ethical committee of many institutions, I must tell you very clear things which probably got a little confused there. In India, 18 years is the age where we say children. And when we talk about the assent, 7 to 12 is verbal, oral consent, and anywhere between 12 to 18 is written assent. And that's very, very important whether you're doing thesis, otherwise clinical work, whatever. I agree that we used to talk about that you just kind of omit the eyes, they used to put the black, and the CT scan and X-ray they used to. Even a histopath, which probably does not have any goddamn names, but if you would publish without the consent of a parent, and eventually the parent comes to know about it, and that would be taken in the court. So let's be very, very careful about the rights of the children and the parents. And as regards the vicarious liability, sure, in the private setup, when you employ your own people and you give them instructions how to go about it, vicarious liability is definitely there. But in a government institution like mine, my juniors are not selected by me. They may even work independently, although they may be in my unit. So unless I'm directly involved in the management of the patient, the vicarious liability does not come to me just because I'm a unit in charge or HOD.
Thank you. Gopi, I think we've been instructed to stop the session. So with your consent, can we please be allowed to stop the session? Thank you.
Quite happy to talk outside. Thank you very much. Thanks a lot.